Good evening. I'm Dr. Rick Duplantis, and welcome to It's Your Health. My guest tonight is Dr. Eric Fontenot, an internal medicine physician hailing from Ville Platte, Louisiana, practices in Lafayette, Louisiana, practices in the All Center across from Lafayette General Hospital. Our topic tonight is congestive heart failure. 1 million hospital admits each year are due to congestive heart failure. Of that percentage, many are repeats. 50% of those presenting with congestive heart failure to the hospital will be repeat patients within 6 months for congestive heart failure again. It costs about $23 billion a year in medical costs to care for these patients with congestive heart failure. Tonight, my guest, Dr. Eric Fontenot, will give us some information on congestive heart failure as it is. Dr. Fontenot, I want to ask you, what basically is heart failure?
Heart failure, as we know it today, comes in or as a consequence of other disease processes such as hypertension, coronary artery disease, myocardial infarctions, various cardiomyopathies, both infectious, restrictive, non-restrictive, and constrictive, and even intrapartum cardiomyopathies. And this process of a heart failure is broken down into several types, but the basis for the public here today is it is a heart failure in simplicity. Basically, forward failure resulting in increased backflow, producing symptoms as we know it, such as swelling, edema, shortness of breath, liver congestion, other organ congestions, renal failure, and hypoxemia in severe cases, and debility as well.
The patient might have shortness of breath. Would you say that's a classic presentation of congestive heart failure?
I'd say it's a classic presentation in the emergency department.
Okay.
It is not so much a classic presentation in the office.
Is that what brings someone to the hospital?
Yes. It's when they're going to get short of breath, of course, they're going to seek medical attention in the emergency department, and hence the diagnosis is made at that time, and then the proper treatment will be administered. And depending on what type of heart failure will depend on, and the severity will depend on admission versus no admission versus consultation. And in severe, really severe cases, such as New York Heart Class 4 cases, there's even preparations for end-of-life issues as well.
Well, I want to ask that question a little bit later, but we will cover that. What's the work of a congestive heart failure? Patient comes in, they're admitted to the emergency room, they are on the wards now. What tests follow? I mean, many people know someone has gone to the hospital with heart failure. I mean, right. Maybe a grandfather, a spouse with heart failure. And you've just listed the litany of possibility reasons why people will present with heart failure. Right. And a lot of those individuals, the shortness of breath, like we said, we talked about that a little bit. But where does a diagnostic test, what comes into play for us from diagnosis standpoint?
When someone enters the emergency department or a hospital type setting seeking emergency care, the first thing we do is basically stabilize the patient, give them oxygen, do a standard workup. And once we arrive at the diagnosis of congestive heart failure, or congestive heart failure is strongly suspected, we'll generally start with, number one, you always want to start with an EKG. And two, you want a good history and physical examination, including a thorough medication history. And number three, a chest x-ray. And number four, a echocardiogram. which is a sonogram of the heart or ultrasound of the heart. And after that, depending on how these tests return and are resulted, will determine if this patient meets criteria for admission into the hospital.
EKG finding of someone with congestive heart failure,
Usually
ST segment, diffuse ST segment depressions, and
in heart failure, if in a very acute systolic heart failure caused by ischemia, yes, you would see ST depression, possibly ST elevation, and that is a very, very serious medical emergency when you have congestive heart failure as a result of a myocardial infarction. That is a real medical emergency.
Well, and then the echo is very helpful in diagnostic. It gives you a lot of information. Ejection fraction, you want to go cover that, and for the wall motion of the heart. I mean, it gives you specific information if it's a valve issue or it's actually from ischemia to some extent, doesn't it?
Well, the ultrasound won't tell you if it's so much from ischemia unless it's used in correlation with the EKG or the 12-lead EKG. But it gives you other types of information, the severity, the cardiac output, the stroke volume, the left ventricular end diastolic volume. All these things.
They're important to clarify their diagnosis to the extent of how bad of congestive heart failure they have.
Correct.
To what degree?
It will correlate to the severity.
Yeah.
It will help correlate to the severity. Always remember that congestive heart failure is still a clinical diagnosis. You know, it is not diagnosed solely on the echocardiogram. It is still a clinical diagnosis.
Yeah, clinical findings. We talked about the echo and the EKG as well. What type of findings as far as the heart rate, for as the heartbeat sounds? What are lung sounds like?
Lung sounds.
Because of the pulmonary congestion.
Classic rails. There will be crackles at the bottom of the lungs, possibly wheezing, very rigorous inspiratory effort. You will see labored breathing in severe cases. As far as for the heart sounds, you might see a diastolic murmur and an S3 sound or gallop that you would hear in severe cases.
That's usually I guess the left ventricular wall thickening. The atrial kick causes that third and fourth sound.
Yeah, in early heart failure, yeah, you will have a thickened left ventricular wall, but in late heart failure, it will actually thin out or dilate out. You know.
I see, yeah. The lab work. What does the lab work tell you in CHF?
Lab work, a BNP or pro-BNP is what we use today. However, again, since heart failure is mainly a clinical diagnosis, the BNP helps to determine severity as well. Cardiologists use this as a tool to follow progression of treatment.
Or actually recovery.
Right.
Is it a measure of recovery?
Right.
That number comes down.
Or relapse, you know.
You know, brain natriuretic peptide, they serve a compensatory function in that they help to decrease the aldosterone production to a certain extent. I mean, it's supposed to dampen that down. That's the body's way of trying to address its own issues, where less aldosterone means less fluid retention, less sodium retention at the same time. And it's interesting that that's a value, that's a number that's looked at from the standpoint of the severity by cardiologists, and even in recovery stage of congestive heart failure, the patient's coming out of it more or less. But the sodium in congestive heart failure, where does that go?
Well, sodium, again, water follows salt. Someone with a high sodium diet with congestive heart failure is asking for trouble.
So is that one of the protocols? You restrict sodium in fluids?
Oh, absolutely. You want a less than a 1 liter fluid restriction if they're in the hospital, with a less than a 2-gram sodium diet, and also you want daily weights and strict recordings of their inputs and outputs while in the hospital. But as far as for the public knowledge here, it's going to be. This is a disease of, it's everything that results from the heart failure that's really going to contribute to mortality here and morbidity. The fluid retention, the shortness of breath, the hypoxemia, the renal failure, all these multiple medications that the patient will now have to be on, you know, as a result of this.
Let's talk about some of those drugs. What's the rescue drugs for congestive heart failure?
Congestive heart failure, the first thing that's administered with someone with congestive heart failure in an acute setting with shortness of breath is going to be IV diuretics, and this is going to basically drain out the backflow, and it's going to help increase the cardiac output and takes less strain off the heart.
Correct.
That's the first thing. The second thing, we're going to give ACE inhibitors, beta blockers, and aspirin as well to kind of increase cardiac output in a different way.
Those three drugs are known to decrease mortality from congestive heart failure.
Beta blockers and ACE inhibitors decrease the mortality. They certainly do. Longevity in congestive heart failure is dependent on a proper medication regimen. It's also dependent on the patient's lifestyle. You know, don't have another heart attack, and what we mean by that is control cholesterol, control sodium. If you're diabetic, by all means, control your blood sugar. Make your doctor's appointments regularly, and really be up on your disease. You know, maybe even read about it. Weigh yourself daily at home. Take an active interest.
Good points. What do you tell the family? A spouse is taking care of a husband, vice versa. What do you tell them? Look, this is what's going on. This is what you really need to address.
I would say make sure the patient takes their medication and the patient is weighed daily. And any abnormal weights that fluctuate more than 2 pounds should be reported to that patient's primary care doctor or cardiologist, so you can prevent a hospital admission.
Yeah. What's the main cause of people being readmitted for congestive heart failure second time around?
Second time around?
The non-compliance?
Non-compliant ranks up there, unfortunately.
Medication, like we just talked about? They're not watching their diet? The sodium is off the charts again?
That's a good point, Rick.
I know.
Let's back up one step and let's medications. Okay. Cost of medications accounts for probably 80% of medical noncompliance in dealing with congestive heart failure patients. You know, you have to take an active role in prescribing these medications on an affordable level to that patient. You know,
True. Yeah.
Ask about their drug coverage, you know, while you're writing these prescriptions. And there are ACE inhibitors that are cheaper than others and beta blockers that are cheaper than others.
Because we've got a lot of generics out and these various classes of drugs have been around for years,
Right.
You know, and many new drugs come out and the older drugs go onto generic and become a lot less expensive.
True.
But, you know, it's a shame that, you know, you've got to put money in front of your health, so to speak, and these people can't afford the costly medications to care for themselves, and then not by any fault of their own, they're being non-compliant due to financial reasons. And are there samples enough? Are there samples enough to cover these individuals who don't? Do the drug companies allow to sample physicians with a number of patients that need assistance with their medications? I mean, it's a real issue, as you say.
Samples are a good thing.
But they're limited to some extent.
Exactly. Samples are exactly what they say. They're samples. You
Yeah.
want to try them out on a patient for a week or two. Then if they do well on this medication, then you write them their monthly prescriptions to stay on this drug. That's what they're intended to be used for. They're not intended to be used for several months of therapy because the patient cannot afford. Every drug company does have a website, and you can apply for patient assistance on that website. You can download coupons. The internet is a great source for this kind of thing. When it comes to drug affordability, also there are prescription assistance programs out there that will also help you if you meet a certain income criteria.
The Medicare, people on Medicare, with the drugs. Does that assist them greatly? Because, majority, 80% of the people over 65 years of age, those are the people being admitted for CHF.
Right. Most plans I see with Medicare covers basically the office visit or hospital stay or emergency room visit, but their secondary which is their supplement, is their prescription coverage.
I see.
Okay, their prescription coverage is very important, and when people hit that age of 65 and they're looking for a supplement, and there's so many of them out there, the first thing I noticed that people look at is the cost of that supplement.
Oh yeah.
More than the coverage, and they don't weigh out what
they're getting for the cheaper price versus what they're getting to pay a little bit more.
That's right.
In overall cover. I mean, you have to cover your health.
You have to cover your health. I mean, if your supplement's a little bit more than the average Joe, but your prescription coverage is better and you're on 10 medicines, you need to go with a higher plan because it's going to save you money in the long run.
Correct.
You know?
Correct. Sure.
And when it comes to medication, patients can be very conservative, not because they want to, but because when you're over 65, you live on a fixed income. Most people do.
Yeah.
You know, and you have to take that into consideration. These patients do have other bills. You know, it does cost to live in this world, and we have to do our best as physicians to help bring out the options for these patients.
Yeah, I agree. You mentioned a little bit earlier on end of life issues with congestive heart failure. Kind of elaborate on that. Give us.
There are 4 stages of congestive heart failure. The most common classification type is the New York Heart Class Association of Heart Failure, and there's class 1, 2, 3, and 4. Class 1, New York Heart Class 1, is considered to have no limitations in mobility and very mild congestive heart failure. Where class 2, you're going to have some but few limitations in mobility and on exertion. Class 3, you're going to have several limitations, and then class 4, you have symptoms at rest, you have multiple limitations, and this is when you hit that class 4, this is when doctors look at maximizing medical efforts, and even in certain instances, if you've been class 4 for more than a year or 2, even debilitating even more, worsening renal failure, more hospital admissions, then end-of-life issues are discussed usually at that time. It's very case by case, you know, according to what your doctor sees in front of him or her, and it's a debilitating disease that really needs attention and focus in this world. And like you said, it's the most common reason for admission into the hospital in the United States today.
So diet and exercise, someone who can, because you list the 4 stages of heart failure. Some people aren't able to get out and walk, exercise.
Right.
But you really focus on the diet, the restriction of sodium, below 2 grams in a regular diet, and that will help them to not go back, to prevent them from going back into congestive heart failure again.
Right.
That and their medication, being compliant with the medication as well.
Correct.
And I guess if they can move a little bit and exercise and get out and walk a little bit, that may assist them to some extent as well, you know, to keep them healthy and prevent coming back into the hospital so readily, so quickly. You want to recap the important points of congestive heart failure in a couple minutes, and give us a recap on
congestive heart failure. I mean, as far as for public awareness and public knowledge, make your doctor visits regularly. Listen to your doctor when he or she makes a change or makes an emphasis on diet, medication, cardiac rehab, home health, and increases or decreases in daily weights. As far as for public knowledge, as far as for preventing CHF, that needs to be focused on preventing the things that cause CHF, such as hypertension, diabetes, heart attacks.
a lot of these things go to lifestyle modification and life taking care of.
Absolutely. you know, you back up 10 years before this patient had congestive heart failure, they probably were hypertensive for quite some time.
Long-standing, yeah.
Yeah, long-standing hypertension, or suffered a massive MI or a moderate MI.
Blockage,
which is blockage in the coronary arteries. It's the things that lead up to congestive heart failure is where prevention needs to be focused. And
you think it's an age-related issue or it's a lifestyle-related issue?
I think it's a lifestyle-related issue, and it starts earlier in the game than people think. You know,
alcohol.
Alcohol is another one. It does.
People don't think about alcohol in the heart.
Alcoholic cardiomyopathy. Yes, it is a reality. Drugs can also cause cardiomyopathy. So, you know, amphetamines, your cocaine, all these things that overstimulate the heart.
Exactly. Yeah.
You know.
Good point. Very, very good points on congestive heart failure. I want to talk a little bit about the specialty of internal medicine. You know, I can attest to Dr. Fontenot being an excellent physician. He's my go-to doctor. He's the doctor's doctor. I go to. I see Dr. Fontenot, he's an excellent physician. He's gotten me out of quite a few lurches in the past, and on a weekend, come over to my house and check me out with an intestinal flu, write the life-saving prescription that I've thought that I was going to die in the process, that saved, you know, helped me to feel better and back on my feet the next day and going to spend Christmas holidays back home. So I can attest to that fact that very compassionate, and there when you need him, and you know, he's got your best interests at heart. I can say that from personal experience. So he's the doctor's doctor, you can say, and that's what internist is. An internal medicine physician is the doctor's doctor, a mastery of every aspect of medicine. Tell me about the clinical practice of internal medicine in your practice, doctor.
Internal medicine, I am a primary care doctor. Internal medicine involves primary care as well as acute care. We cover in-office, in-hospital, and also we do a lot of geriatrics, long-term acute care as well. I guess probably one of your better ways to explain the specialty of internal medicine is the question that I get a lot out there is, what is the difference between a family practice doctor and an internal medicine doctor?
I bet you do. Yeah, it's confusing to a lot of people.
Yeah.
Tell us. Yeah.
When you think of primary care branches off in basically to those two. You know, your old-fashioned GP back in the 60s, you know.
He did everything.
He did everything.
All kind of surgery. He did gallbladder surgery.
Delivered babies.
Yeah, you know.
Oh, yeah. Treated
tonsils.
Heart attacks.
Yeah, things have changed, though. Things
have changed. That GP, so to speak, has broken down into a family practice doctor and an internal medicine doctor.
Okay.
So, and what is the difference between those two? The difference between those two is a family practice doctor does a lot of acute care in the office, does certain procedures that internal medicine, you know, that we don't do, such as, you know, pull toenails or
minor surgery. You don't do a lot of minor surgery.
I don't do a lot of minor surgery.
As such, yeah.
You know, they do sutures and other odds and ends. Basically, from every aspect of the family. They do some pediatrics. They do some OBGYN, pelvic exams. They do preventative medicine. They do.
Internists you do preventative medicine too.
We do preventative medicine too.
But you don't do the OBGYN aspect of it.
No.
And you don't do pediatrics then.
Correct. The family practice doctor tends to be more centrally located in the office. There are some family practice doctors that still go to the hospital, and they're certainly well capable of doing so. Whereas the internal medicine doctor basically branches off of, basically represents the specialist. You know, we train in neurology, cardiology, pulmonary medicine, endocrine, and
you're training in those areas, those complex areas of medicine, to manage these conditions.
Yeah,
it's more extensive.
Right.
I know that from the training aspect of it at UMC.
Even rheumatology, and basically, when you need to see a specialist, the internal medicine doctor is the one to go to sort of bridge that gap between you and the specialist. In other words, the internal medicine doctor will give you the first line treatment, and he will see you through your problem. And if it's a little bit either too chronic or too complex where you should be followed by a specialist, then the internal medicine doctor will set that up for you. In the meantime, the internal medicine doctor will give you that special treatment you need that a specialist would give you for a certain amount of time until you can reach that specialist, because some specialists are very hard to reach. Some of them are backed up with appointments, 3, 4, 6 months.
But, you know, it's also good that you are in that mix, so to speak, and you are orchestrating them branching from you to a specialist, because the specialist knows what you're doing and you know what the specialist, so you're both on the same page with that patient. I think that's very important, that communication between the internal medicine physician and the various specialists. So you orchestrate, you bring in, even in a hospital setting, as an internist, you bring in consults from those people that are needed, but you are cognizant of what they're doing, and you take part of making sure the patient is compliant, and you monitor their medications and their condition as well. When they exit, the specialist will exit at some point, and you will maintain that management and controlling that patient's condition from that point on. That's what I felt. I just, you know, I think it's a great, you know, specialty that, you know, very demanding on the doctor that goes in internal medicine because of the mastery of all those branches of medicine that must be acquired. And, but, you know, serves a very good purpose in medicine, and not the traffic cop that people think that an internist is, but a treating physician that manages these complex conditions.
Right, and that's in the office and in the hospital, and even in critical care settings.
Correct.
You know, we admit to the ICU, and we try to manage every level of care. That's within our focus, and it's a real benefit to the public, and I think as an adult specialist, you know, I think as a person gets older, they can continue seeing their family practice doctor, no problem. But someone with multiple complexities like congestive heart failure and diabetes and hypertension and uncontrolled cholesterol, and might be on dialysis at the same time, you're going to be better off with an internist in the long run.
Sure, sure.
You know, just to make that point.
Due to the complexity of the nature of some of these medical conditions.
Correct.
You know, I need somebody with a little bit more depth in those areas, and I think it's a very good point.
Sure.
You know, it's kind of cold now. We're filming on a day that's very nasty out. I want to say that.
Yes, it is.
It's cold, rainy, and wet. Sure. A lot of people have been sick. I've been sick a couple of days ago, lost my voice just about, and got rescued back, and Dr. Fontenot has helped me with that medical issue that I had, and I'm able to speak tonight because of it. But, you know, you're seeing a lot of people with sinus infection right now. Eric, you know, any advice to the people out there in this cold, nasty weather that have to be out in this weather to protect themselves?
Basically, wear your coat, protect yourself from the elements, and use universal precautions. Now's the time where we as adults really need to use universal precautions, because viruses spread in cold, wet air very easily, and you know, frequent hand washing, maybe clean the doorknobs in your house, you know, more than once a month. Clean them more like once a week. If you have kids in the house, make sure they wash their hands. It helps control the spread of viruses.
And many people get bugs that come along from their kids. They pick them up at school and they bring them home, and one person gets it.
Kids.
And then it's like typhoid, everybody in the family gets the bug.
Right.
Kind of shares it more or less, and then everybody ends up with that infection, more or less. You know, we're in flu season, and I just reading some of the stats on the flu now. It's in 43 states, widespread now. It's the type A, and of course we missed the vaccine on this. And then the CDC says that, you know, something on CNBC. I said, hey, we're working on a 10-year vaccine for this. Well, listen, we're missing it from year to year. You think a 10-year vaccine for the flu is something that's plausible, and you think that's going to address the flu bug, because we can't catch the right strand from year to year? Your input on that?
It's going to be a hit and miss type of a thing, as it has been until virology has come down to a more discernible science as far as for being more predictable. I don't think that a flu vaccine is ever gonna be 100% preventative ever. I think in our lifetime, Ricky.
Yeah, yeah. Well, you know, some people don't like shots. You know, we both. You know, some people don't like needles. Some doctors don't like
the government.
Their own.
Yeah,
you know.
they recommend it. The CDC recommends a yearly flu vaccine. Yeah. Now, if it helps,
give us the guidelines. Okay, who should have a flu shot?
Who should have a flu shot? Anyone that's at, I would say, anyone that's at higher risk for or in a high risk environment. School-age children, healthcare workers, maybe prison workers, public service workers, anyone with a lot of public contact out there.
I see.
You know.
So it's not just an age and medical condition thing.
No, it's not.
It's where you're at in the you know.
They stress it more in someone over 65 because the implications, it could really, the mortality rate increases after you're 65 if you contract the flu, and that's why we push it, and Medicare pays for it, is because it's mortality if you did contract it over 65, because you don't handle it like when you were 21 years old.
Correct. Yeah.
You know, it really puts you down and really can cause some problems.
Right. So those over 65 recommend, of course, to have the flu vaccine. Excuse me. Yeah. Still recovering from my sinus issues, of course, here. I wanted to ask you regarding the flu. What can the people do to prevent the flu? Is it the same thing, hand washing and the doorknob thing, and you know, not getting around people with the flu, kind of just common sense type of thing?
Common sense, universal
what do they take?
Precautions.
What do they if they have the flu and they go to the doctor, they do the nasal swab, do they get on the medication, Tamiflu and those type of things? Your opinion of that?
Tamiflu, if you're symptomatic less than 72 hours, you're a candidate for Tamiflu. Greater than 72 hours, its efficacy is not very good.
I see, yeah.
It's very expensive.
Yeah, it is.
Hydration, bed rest, fever control, basically supportive measures is all we would recommend.
When are you non-contagious? Once you're recovering from the flu, when do you know that, okay, it's okay, somebody can come and see you, that they're not going to catch it?
7 days.
Is it after you break the fever? Or is it
7 days after you break fever, you're not contagious anymore.
Okay, good point. Okay.
If you want to take a chance and narrow it down to 5, hey, that's you know.
Yeah, yeah. Well, I know people that, you know, will go to somebody's house if they think they're sick and they wear a mask. You know, but not a bad idea, not a bad practice at all. Right. Eric, I think you've given some great points on, you know, congestive heart failure, which we've covered tonight, on the topic of internal medicine, actually, exactly what is internal medicine. And also we've talked about the flu, and I hope the viewing audience has reached an understanding of these topics and have gotten some ideas and some, you know, things that they can do to incorporate into their lifestyle. And definitely try not to get the flu, and if you do get the flu, you know, see your physician and take the medication and take good care of yourself. I want to thank Dr. Eric Fontenot for coming on the show today and talking on these very important topics, and I want to wish you a very pleasant evening. And don't forget to like us on Facebook. We have a Facebook page called It's Your Health, and like us on our page, and leave any comments there you might have about future program you'd like to see on this show. I'm Dr. Rick Duplantis, and this is Dr. Eric Fontenot, wishing you the best of health. Have a good evening. God bless you.
Thank you.
Okay, that's probably didn't talk this time. Hey, I didn't.